joining us, and thank you to our Facebook Livers who are joining us from home and who are unable to make our Cardio-Oncology presentation tonight here at Cancer Support Community. We are so grateful to Franciscan Health and their cardiology team for being here tonight to help put on this lovely presentation. My name is Rachel. I'm the Program and Outreach Coordinator here at Cancer Support Community. As always, thank you guys so much for taking the time to be here and participate in our education programs. If you would love more information about what we do, feel free to come and see me. I'm happy to talk to you about it. I am going to hand it over to Dawn, and she's going to tell you a little bit about our speakers tonight and a little bit about Franciscan Health. Thank you again for being here. We truly appreciate it.
Thank you. We're so happy to be here. Thank you all for coming tonight. We appreciate you coming and taking some time out of your busy schedules to get some education, and thanks for people listening online. My name is Dawn Wilkes, and I work at Franciscan Health. I am fortunate enough to work with cardiologists and more so oncologists with our Cardio-Oncology program. Franciscan Health are pioneers in the cardio-oncology world, and we started out a few years ago and have built a program that other people in the country are coming to us to learn. So we're very proud of that. And our team consists of cardiologists, oncologists, nurse navigators, and multitudes of other people that work together to make it all work well. So tonight I'd like to introduce our speakers. We have cardiologist Dr. Vijay Rao. He is a cardiologist with Franciscan Physician Network Indiana Heart Physicians. He's been there since 2011. He's from Carmel, Indiana, and received his undergraduate degree in biology from DePaul University. He graduated from the Medical University of South Carolina and completed his residency in internal medicine at Duke University Medical Center. His fellowship was completed at the University of California, San Francisco. He's coast to coast. And Dr. Rao also has a PhD in molecular and cellular biology and pathobiology from the Medical University of South Carolina. He is board certified in internal medicine, cardiovascular disease, echocardiography, nuclear cardiology, and heart failure. He has a special interest in heart failure, heart valve disease, and cardio-oncology. And a second speaker tonight is Dr. Meghana Raghavendra. She is a medical oncologist at Franciscan Physician Network Oncology and Hematology Specialist, and she is the co-medical director of the Cardio-Oncology program at Franciscan Health. Dr. Raghavendra received her medical degree in India and completed her hematology oncology fellowship at Gunderson Health System in La Crosse, Wisconsin. She is board certified in internal medicine, medical oncology, and hematology. Welcome, Dr. Rao and Dr. Raghavendra.
Here. So nice to meet you all. Thank you for coming again. This is really exciting, a terrific crowd, and for those of you on Facebook Live. So again, my name is Vijay Rao. I've been deemed Aladdin apparently tonight by one of our patients. so we're going to take you on a magic carpet ride, and we're going to have a really good time. So we're going to talk today about a topic that has a lot of interest to me and Dr. Raghavendra and really the community. It's called cardio-oncology. Maybe a show of hands. Has anyone heard of that term, cardio-oncology? Got one, two maybe? So not too many folks, so that's good. There's an opportunity here for some education. You may be thinking, what in the world does cardiology and oncology have to do with one another, right? Cancer, heart. What's the connection? So what I'm going to do over the next about 10-15 minutes is kind of give you a background on what this field is and why we've developed a program to try to help cancer patients get through their care. So again, the title of the talk is, I just threw this together, Preventing Broken Hearts in Patients with Cancer. All right. So this is an initial slide that basically shows you from the Centers for Disease Control, CDC, 2018. These are the number of deaths in the United States, okay? And here's by the number of deaths by the hundreds of thousands. And you can see all the way over here on the left, the top two causes of death in the United States in 2018 was heart disease and cancer, okay? And when you put those two together, it's more than all the other causes of death combined. So this is it's a very prevalent, both of these, heart disease and cancer. And as I'll show you in a second, it tells you that, the good news is that a lot of patients are surviving their heart disease now. Cardiology's made a lot of strides in heart attack care with angiography and, statin medications and lowering cholesterol and trying to get people to quit smoking. A lot has happened in the cardiology arena, which I'm very proud of, that we've really dramatically reduced mortality. People are living much longer. They're surviving those heart attacks, and they're really doing a lot better. So that's been on our side. But then on the flip side, and thanks to work by Dr. Raghavendra and the oncology community, and there are so many new therapies for cancer, and that patients are surviving their cancers better than they've ever done in the past, which is terrific, right? So people are living longer, and then cancer survivors often end up with heart problems because it's just a process of aging. And the heart patients who survive their heart issues develop cancer. So you can see there's this connection that as the population ages, as we survive each of these particular diagnoses, there's a likelihood that there's going to be some cross coverage here, that the people are going to have multiple issues. All right. So this is just a figure showing you in 2000. This is 1990 to 2008 across the bottom here, and this is giving you mortality rate per 100,000 for patients who have a diagnosis of cancer. And the good news is this red line is telling you all the way from 1990 out to about 2008 that the cancer surviving is going way up. It's getting better and better and better. And that's reflected in the green bars going up that way, which tells you the number of cancer survivors. And you can see in the millions that the survivors are going up, the mortality is going down. And if I were to take cardiology and cardiovascular disease, I could just put that right on top of this figure, and it looks almost identical to this. Cardiovascular mortality is coming down, and the number of heart survivors, coronary artery disease survivors, is going way up. Okay, so these are good things. And this is just a pie graph kind of giving you a sense, and this is again a little bit dated, but 2008, it's telling you that different types of cancer and the number of survivors in the United States. And there's some different areas. You can see that a big section of that red over there in the top right, is female breast cancer survivors. This was again 2008, but 22%, almost 2.5 million breast cancer survivors. So a lot of survivors out there. And you can see hematologic malignancies like leukemias and lymphomas and myeloma, about 1 million back then. And those numbers are going up. So we have a lot of survivors. Now, in particular, I'm showing you these two areas because the treatments for those patients often can have heart issues, heart complications. And so as I'll take you through a little bit of this, you can see that those are the folks that we're really focusing on now, is this survivorship group, and how can we prevent any heart complications. So this is a figure that shows you breast cancer population. These are patients who had ductal carcinoma in situ, which is a type of breast cancer. And this is on the x-axis here is the age at diagnosis, okay? And this is the total number of deaths, okay? And what you can see is that if you, in this blue graph here, this is cardiovascular death, and this green bar is breast cancer death. And you can see that this is what that person would potentially die from, okay? So the earlier you are making a diagnosis, here's the breast cancer mortality. The later you are diagnosed, breast cancer mortality is going down. People are surviving the breast cancer, okay? But as you get older, what's happening to those patients? The cardiovascular mortality is going up. So this is telling you we're identifying patients with cancer earlier, breast cancer, we're taking better care of them, we're able to get them through their breast cancer, and breast cancer is not the leading cause of death in this population. They're surviving the cancer. But what's happening in this purple bar here is that's cardiovascular death. So they're dying of heart attacks and strokes. So this really brings up the idea that, okay, we're going to take care of the cancer patient. We're going to get them through with their chemotherapy and radiation and all the number of things. But that once you get into the survivorship period, we cannot forget about cardiovascular disease. And that we really need to focus on that population. We need to make sure they're exercising, that they're quitting smoking, that their diabetes is being treated, that we're doing all the things that we typically do, but we haven't thought about this population. for cardiovascular risk, but there's a link. There's a link, and we can't forget about that link. So this is a cartoon, and this is kind of talking about, I mentioned all these great new cancer therapies, and there are a tremendous number of new cancer therapies out there, from harnessing the immune system to all sorts of novel ways of trying to attack cancer. And this is the pharmaceutical industry who, a number of these new cancer therapies are coming from pharmaceutical industry. And they're coming here to the lifeguard, the FDA, and there's FDA is looking at the pharmaceutical industry who's coming at them with new drugs and new therapies every month. There's 3 and 4 and 5 new therapies. And the FDA has to sit there and say, look, do I approve this drug? Do I not approve this drug? And there's a lot of controversy about this, right? So for a patient who may not have a lot of other options, they're saying, FDA, approve the drug. If there's some benefit, let me get it, right? These are folks who really may not have other options. So there's this pressure on the FDA to approve things, and approve them quickly with very short trials, 3 months, 6 months, 9 months. And there's some benefit seen, we gotta move on it, right? But what is also important is that in those short trials, we haven't had a lot of time to look at some of the side effects that could occur over time. And so many of these trials are very short, and there is benefit, and so they move forward quickly through the FDA. But what we are finding out after the fact is that, hey, now this drug is out in population, it's being used, and we're seeing some of these side effects that they didn't see in the trial because patients hadn't been on it long enough. And some of those things are heart related. So this is kind of where that cardio-oncology field is coming into play, is that we need to start studying these things. We need to start following people longer on these types of therapies and identify what could be happening. If it's happening, how can we prevent it? Nobody wants to, get through their cancer care and end up with heart problems, right? And so that leads me to this quote, which always caught me. This is one of the first conferences I ever went to in cardio-oncology. This was a quote that was given there, and it just resonated with me. It hit home, coming as a cardiologist to this field. And it says, one of the goals of cardio-oncology is to prevent the cancer survivor of today from becoming the heart failure patient of tomorrow. We don't want the heart failure, right? We want to take care of the cancer, we want to do it safely, and we want to prevent. And that's the key term here, right? Prevention. Identify early who's at risk, do what you can to prevent this, whether it's maybe altering the chemotherapy regimen or dosing or putting on heart protective medications. This is where cardio-oncology is really taking its key role. And with that, that's just a very quick introduction to cardio-oncology. We're going to do a couple of cases with my colleague, Dr. Raghavendra here, and we're going to talk about how going through a patient scenario, well, how does cardio-oncology play into the care for that patient? And with that, I'll turn it over to Dr. Raghavendra.
Good evening, everybody. How's everyone doing tonight? I'm excited for this riveting lecture. So Dr. Rao has been doing this for nearly 5 years, and I have joined him, I think, for the last 3 years, and it has been a wonderful program. And Carrie and Holly are our nurse navigators who have taken this program from when we started as a little infant and have grown this to almost a national stage. So we're very, very excited about this program. So like Dr. Rao alluded to, cardio-oncology essentially is a specialty which is serving as a bridge for me as an oncologist for patients who have cancer. And when patients come to me with cancer, our goal at that time is to say, how do I diagnose you? How do I figure out what the right treatment plan is? What can we do in terms of treatment that can give you the best outcome, help you live the longest, and the best life you can live? So all of those are important. But it's also important for me to take care of patients as a whole, right? We're not just taking care of the cancer, we're taking care of a person. So it's very important for us to choose treatment that don't affect other organs adversely as best as we can. We want to be careful about it. And what's the number 1 organ in the body? We don't want Dr. Rao to cure this.
The heart.
Maybe. So we do though, we do take it seriously. We want to make sure that we take care of the heart as best as we can as we are approaching our patients with treatment options, right? So when I see patients, as I'm diagnosing them with cancer, as I'm recommending treatment options, I'm also looking to see what their other organs are doing, what their heart is doing. Are these patients who have pre-existing heart disease? Then I need a staff Dr. Rao counsel. as we go through treatment, as we monitor these patients, are these patients who develop heart conditions? Then we get Dr. Rao involved. Do we make modifications? Do we change treatments? How do we go about this to make sure the patients get the best care they can, so we can leave the cancer behind or continue with the cancer and make sure we're taking care of the heart as well? That's what cardio-oncology does, right? So we work hand in hand together to make sure we give the best outcomes possible for patients. So the best way I learn is to kind of take you through a journey. So we'll do that today, okay? So we'll talk about the case presentations. So the first patient we're going to talk about is a 65-year-old gentleman. He came into the office. He came into his primary care physician and said that, he has got this lymph node in his neck. And he thought initially it was strep throat, went away, got worse, and eventually came to a point where it was big enough that it wouldn't go away. It was very visible and painful. So he came to see his primary care doctor. And eventually they got a CT scan, and quite a few lymph nodes were kind of involved, not just in his neck, but also in his chest, in his belly, his spleen was large. So they got a biopsy, and that said that he had a kind of an aggressive lymphoma called diffuse large B-cell lymphoma. Okay, so this is fairly common, and the patient also has a history of high blood pressure, has a history of high cholesterol, he has diabetes, fairly well controlled, fairly active and healthy, really no other significant issues when he presented. So we got a PET scan, and it showed that he had stage 3 lymphoma at that time. So this is a picture of the PET scan. I borrowed this one from Google, but that right there is his spleen. Okay, normally the spleen is a kind of an organ. It's tucked under the ribs. You don't really feel it, but that one's fairly large. You see that he has lymph nodes here in his lower abdomen, and as you go up, you see the lymph nodes up in his neck as well. Okay, so that's from his lymphoma. So typically what we do is, as we see these patients, we say, hey, we see that this gentleman has high blood pressure, he has high cholesterol, he has diabetes. All 3 of these increases risk for heart disease. So we said, okay, let's get the cardio-oncology team involved. Let's make sure that we're taking care of him. And then he had an echocardiogram, which is an ultrasound test of the heart, which measures how well the heart is functioning. It looked great. So we began treatment with this cocktail. So one thing about oncology is, like, we love alphabet soup. Everything is about alphabet soup, right? So we gave him something called R-CHOP, right? So of these 4 medicines, this doxorubicin, the one in red, that's the one we need to watch for, okay? Particularly with this. So he got 2 rounds of treatment, we got another PET scan, and all his disease was gone. We couldn't see anything. So he had a fantastic response to treatment. But unfortunately, I did a bad thing. So he progressively got short of breath. He had significant swelling in his legs. So we had to figure out what was going on with that. We couldn't figure out why the treatment had actually caused this effect, right? So we said, okay, let's see Dr. Rao. Dr. Rao got an echocardiogram, and his ejection fraction, that's the squeezing capacity of the heart, had gone down from normal to about 35%. So his heart was not really functioning as well as it should have, right? So we did a great job in taking care of his cancer. We got him into remission from his cancer with 2 rounds of treatment, but unfortunately, we saw that he had a compromised heart function, okay? So he ended up getting hospitalized for congestive heart failure. So while he was in the hospital, we treated him for symptoms of CHF. Dr. Rao and his team came on board. They helped manage the medications, adjusted a few things, got the fluid off his body. We discontinued this particular chemotherapy, which we thought was a culprit. That was the one that can hurt the heart. So we discontinued that chemotherapy. But we always have a backup option, right? That's what oncologists do. We want to make sure we have a good backup option. So we switched that and gave him a different alphabet soup called RCEOP. So we switched out the doxorubicin for this medicine called etoposide. He got 4 additional cycles of treatment without any further compromise to his heart. And now he's nearly a year out after having finished his treatment, and he continues to remain in remission and continues to follow with cardiology, and we continue to manage his heart. So he's doing very well. All right? So I'm going to just turn this over to Dr. Rao, and he's going to talk to us about how he helped with this patient.
So again, this patient ended up doing quite well after everything, but there was a process that happened when the patient received that chemotherapy, and again, started off with normal heart function, had some risk factors, high blood pressure, diabetes, and then had a pretty precipitous drop and then developed fluid overload secondary to that. Now thankfully he recovered, but I want to give you a quick sense. This class of medications, the anthracyclines, just a quick historical perspective, this dates one of the first chemotherapy agents, dates all the way back to the 1950s. There was a compound called daunorubicin. They actually isolated this from soil bacteria, believe it or not, from Streptomyces speciecis. And they actually found that when they gave that an isolated compound to tumors in mice, it actually had dramatic responses. It really worked well for tumors. So eventually it moved over into humans. It was treatment for leukemias and lymphomas, and still is to this day really a standard of care therapy in this class, the anthracyclines. So as you can see here, among some of the most effective anti-cancer treatments ever developed, and it's effective against more types of cancer than really any other type of chemotherapy. And the one that Dr. Raghavendra mentioned, R-CHOP, is a very common regimen that's given for a number of different types of cancers. Mechanism of action, don't worry about all the details, but the chemotherapy does get into the DNA, RNA. This is the molecular side of it. There's a particular enzyme called topoisomerase 2. I will be quizzing you on this later, so make sure you remember that. And it creates free radicals and what essentially leads to cell death, okay? And it's very effective at doing that, okay? But the problem was, what we ended up finding out, again, well after the fact, is that patients would have received large amounts of this chemotherapy, this anthracycline chemotherapy, and were in remission, but then showed up like our patient did, but many years later, and in congestive heart failure, with heart functions that our patient had 35%, but some of these patients would have 10, 15, 20%. And in fact, some of them ended up being so sick from that they ended up needing a heart transplant. This is after completing chemotherapy and being in remission from the cancer. So this was a very big troubling thing. The cardiology community, along with the oncology community, start to recognize this pretty early and said, well, this is that whole concept, right? We don't want the cancer survivor of today to be the heart failure patient of tomorrow. So what did they do? Lots of research went into this, tons and tons of research. And what they ended up finding out is that it's very dose dependent. So on the bottom here, this is the probability of developing congestive heart failure on the y-axis here. And as you go from left to right, that's higher and higher doses of the anthracycline chemotherapy. And you can see, you get to this point where you get to about 400 milligrams per meter squared for that patient, and the curve starts to take off. It's going up and up and up and up. And that's where the probability of congestive heart failure starts to really rise. And it was not uncommon for folks years and years ago to get 1,000 milligrams per meter squared. I mean, there were some regimens that, again, before we really knew about this toxicity, people were getting a lot of this type of chemotherapy. So this is a very important study, and you can see this is 1996, but this is one of the classic cardio-oncology figures because it tells us we've got to identify this early, but we got to cut the dose. You can't be giving such high levels of this particular chemotherapy. And because of this, the community got together and they've created regimens now that don't go anywhere near the high levels that you see in the past. And it's really dramatically reduced the incidence of this type of cardiotoxicity. So this was a real win and we learned a lot more about it. So here's a figure that gives you some of the predictors. How can we predict who's going to develop that cardiac toxicity when they get an anthracycline? And some of it I just mentioned to you, the cumulative dose. So now, this is doxorubicin, which you just heard about, more than 240 milligrams per meter squared, the risk starts to go up. I showed you on that prior figure 400, but even down to 240, people can develop some types of toxicity. So the newer regimens that include this kind of halted now, right around 240, most of the regimens. Epirubicin, you can see the type and rate of administration matters. So there's they can do something called liposomal doxorubicin, so they change the formulation of this particular anthracycline so it's not as toxic to people. The rate of administration matters. It really is interesting that if patients had received radiation therapy, also in addition to this type of chemotherapy, it puts their risk up dramatically. So that is another thing we've learned. The extremes of age, and I say extremes, sort of liberally here, but less than 15 or greater than 65, those folks are the ones who are at the highest risk of developing this type of toxicity. Women, it turns out, are more susceptible than men. Pre-existing cardiovascular disease, that's that diabetes, hypertension, prior history of heart attack. If you've had a history of congestive heart failure, boy, you're at much greater risk. And then there's high blood pressure. Just simple old high blood pressure puts you at high risk. So these are sort of risk factors, and as Dr. Raghavendra sees these patients, she's thinking about all these things. Is this somebody who's going to be potentially at risk with some of these risk factors? We need to give that chemotherapy regimen. Thankfully, we now know the doses are much less, but toxicity still does occur. And so that's where this whole cardio-oncology consultation and service can provide some benefits. So is there something you can do when it happens? Well, there is a lot of information out there now. Again, anthracycline cardiotoxicity has been around for years. Doses have come down, protective measures have been put in place. These are some of the standard cocktail of medications that we use in cardiology, but it turns out they're very protective in the cardio-oncology sphere. One of them is called an ACE inhibitor. That's a blood pressure lowering medicine. Angiotensin receptor blockers, beta blockers you may or may not have heard of. There's those statins, those cholesterol lowering medicines. It turns out they actually have really significant benefits in the cancer population. And then there's this medicine called dexrazoxane, which is more and more, this has been around a long time, but it's very protective. It had not been used because there was this fear that if you gave that medicine, then the chemotherapy wasn't going to be as effective. So people never really got into this. Now there's more and more data, new data, that show it has no effect on the efficacy of the chemotherapy. And it has dramatic protection from cardiotoxicity. So I think we're going to start seeing a lot more use of this in the future because it's very well tolerated by patients. And again, if it's not affecting cancer outcome in a negative way or the efficacy of the chemotherapy, but preventing the cardiotoxicity, it's a win, right? It's a win. All right, with that, I'll move it on to the second case, Dr. Raghavendra.
Everyone learning tonight?
Can I ask a question? Everybody ask a question. So like those drugs that you just said, will you put them on a drug at the same time you're administering chemo drugs, or would that be like if you saw a problem afterwards?
Like the dexrazoxane?
Or like the beta blockers or statins, all of those?
Yeah.
That's a great question. So that's sort of preemptively putting somebody on something to prevent the toxicity. We don't have a lot of clinical trial evidence,
Okay.
but I will tell you if there's somebody that's high risk, certainly on the echocardiography, if there's any drop in the heart function at all, or I start to see there's something called strain, which is another kind of technique that is looking at how the heart twists and torques, and it turns out that even though the heart's pumping great, if it's not twisting properly, which is an early marker, it tells you something's going on. I will preemptively put those patients on some of those medicines that we just talked about to try to prevent anything from going. So the goal is to catch it early, and that's why we do actually screening programs. So in this particular agent, which we'll talk about in a second, patients are getting echocardiograms every 3 months to screen for drops in heart function. We don't do them as often with the anthracyclines because we kind of know about dosing and whatnot, but definitely a great question. We are always looking to see if we can put them on protective things. And these medications are pretty well tolerated. I mean, they're blood pressure lowering medications. So, as Dr. Raghavendra sees a lot more of these folks than I do, but there's a lot of low blood pressures and dehydration and anemia and low blood counts, and it's a little tough to get them on a whole lot of that medicine, but there is evidence to say if you can even start low doses, you can have some protective benefits. All generic, not expensive medications, and not long-term medications. A lot of them are just for the short term to get them through the therapy. But we need more studies, but that's a great question.
And that's like Dr. Rao said, we actually are enrolling patients into trials, right? We ask patients to participate in studies so we can actually answer that question appropriately. But for patients who already have those risk factors, they go ahead and start the medications anyway.
Gotcha.
But if I have a very young person who has no heart disease, then Dr. Rao is monitoring them very closely, and any change then we start those medicines. So
Okay, that makes sense.
that's an awesome team that helps us with our patients. So this is the story of our second patient, right? So this is a very, very young woman who came to our office. 34-year-old came in with a lump that she palpated in her breast. She kind of felt that when you're 34, you feel a lump in your breast, you're not thinking cancer, unfortunately. But as time went on and the breast didn't get any, the lump didn't get any better, it grew to be about an inch in size. She again went in to see a primary care doctor. Fortunately, we got a mammogram and an ultrasound. And this is what we call an MLO view of her mammogram. So this is the front of the breast, and you see this little area right here, that little lump that you can see on that mammogram. Okay. So we then she underwent an ultrasound and a biopsy. Unfortunately, did confirm that she had breast cancer, which is a typical kind of breast cancer. It's called the infiltrated ductal carcinoma. She had lymph nodes that I could feel during her visit, so we went ahead and got the PET scan to see how far the disease had spread. And again, she's only 34, but we found that she also had, in addition to the lymph nodes in the armpit and the breast lump, we also found that she had disease involving her lungs as well as bones. So she had stage 4 disease when she presented to us. We get something called prognostic markers. So these are markers on the surface of the breast cancer cell that tell us how to treat these cancers. So the ER is the estrogen receptor. PR is the progesterone receptor. So these are the hormones that might feed the cancer if the receptor is being expressed on the cancer cell. So she had both of those, and she had what we call a HER2. So this is a growth factor receptor, which is present in the cancer cell as well. So this is what we call a triple positive breast cancer. And it's one of the aggressive kinds of breast cancer that she had. So typically when we find somebody who has involvement of the lung as well as the bones, when we have stage 4 disease and has HER2 positive disease, we want to try attack the HER2 receptor and close that down, shut it down so the cancer cell cannot grow and multiply and divide. So it's very targeted treatment. And we do that with these two antibody treatments. These two are not chemotherapy medicines. These are medicines which target the HER2 receptor, which is called pertuzumab or Perjeta, and trastuzumab, which is the Herceptin. These are combined with the chemotherapy medicine called paclitaxel. Okay, so she gets both of those medicines together. Denosumab is a bone strengthening medicine because she had involvement of the bone. So after 3 months, she had a PET scan, and again, a very, very good response to treatment. Nearly all of that disease had gone away. We didn't really see any active disease at all. So at that point, we dropped the chemotherapy medicine, switched her to hormone pills, but continued the HER2 targeted treatment. So one of the things we know about the HER2 targeted treatment is as the HER2 receptor is overexpressed on the breast cancer cell, that particular receptor is also expressed on normal heart tissue. Okay, so as we give treatment that shuts down the HER2 receptor, it's great from a cancer standpoint. Dr. Rao doesn't like me very much when I do that though. It makes the heart nice and working. So as we do that, we see, so if this is a breast cancer cell, if this is a normal cancer cell, so that's your growth factor receptor, that's the normal HER2. So when the growth factor kind of comes and binds to it, it actually causes the two portions of the receptors to come together. So that's what we call dimerization. That then causes, pretty much like dominoes, if you will, kind of causes downstream activation of the nucleus, and then it causes the cell to divide and grow. That's normal, that's great. But this is what happens when there's breast cancer, right? It actually has too many of these receptors, so it's binding to every little growth factor that's available, and it actually causes dimerization, so it then causes the breast cancer cell to grow really quickly and multiply and divide. What does Herceptin do? It kind of gets in here and blocks it. So it doesn't let that attach, it doesn't let the receptor come together, so the cancer cell cannot grow. Okay, so that's the ligand, that's how it is binding together after the antibody or the factor comes in to bind it, but that's what Herceptin is doing, right? It doesn't allow it to come together, so it just shuts down and the cell dies, okay? So typically, because the HER2 is expressed on the heart cell, what we will do is we will say, okay, let's go ahead and get echocardiograms, let's monitor the heart function. We do that every 3 months. So with this patient, we did exactly that. So she had a normal ejection fraction. She's 34. She has no other medical problems. She should have a great heart. But about 12 months into treatment, we saw that she had a teeny amount of decrease in heart function. It dropped to about 45%. We don't like that. She's only 34. We want to kind of try to keep her heart going. So we took a break from her treatment, and we got the Cardio-Oncology team involved. And as we talked about her, as Dr. Rao alluded to, he got her started on all the right medications. We took a break for about 3 weeks, repeated an echocardiogram, heart function was back up to normal again, and we were able to continue treatment, and she's now 2 years out. I actually saw her last week, and she's kicking ass. Oh, she's doing great. She's doing fantastic. Yes, no further decline in the heart function. I'm gonna get fired, aren't I? Yeah. Yeah, but she continues to get her medical treatment, and she's doing really, really good. All right, so that's Dr. Rao for them.
So the question is, how do we screen for heart toxicity? And I'll just give you a quick, one is obviously a history and physical. Talk to the patient, right? Ask them, and it's difficult sometimes because there's fatigue. I mean, anybody who's had cancer, fatigue, sometimes swelling in the legs, just not feeling good, and short of breath, you know, there's all of these symptoms, and Yet a lot of those symptoms overlap with heart symptoms. In congestive heart failure, people sometimes just feel really fatigued, and boy, that kind of overlaps. How do you tell the difference, right? But swelling in the legs is a big one. If you have new onset of, sometimes people will push their finger into their calf there and it dents, and that's called edema or swelling. That's a sign that you could be having congestive heart failure. Another big one is if you're lying in bed at night and, boy, I can't breathe when I lay flat. I have to sit up. That's called orthopnea. And that's another sign that fluid could be building up in the lungs. So these are the kinds of symptoms that we have to ask our patients, hey, are you having any of these kinds of symptoms? Are you getting really short of breath just walking across the room? We will get EKGs, so EKGs can be very helpful. You've probably seen some of those where they put all those little stickies all over you, and they're looking at the electrical rhythm. We can pick up heart attacks, we can pick up arrhythmias. Sometimes people will go into a rhythm called atrial fibrillation, and the heart will get very irregular and people will just feel miserable. So those are things we can pick up. There's biomarkers, there are labs that we can get. So there's something called a troponin. That's what we check when people are having, if someone comes in with chest pain into the emergency room, we're getting that blood test to see. That's what happens when heart muscle cells are dying. They release their contents into the blood, and one of them is troponin. So when we start to see that going up, we know something's going on in the heart. And that may not just be a heart attack, it could be any number of things, but something is going on in the heart. So we use troponins quite regularly. BNP stands for brain natriuretic peptide. That's a hormone that's produced in the body when the pressure gets too high in the heart and fluid is starting to build up. That congestive heart failure that we talk about, congested, the fluid, that number starts to go up. So these are some screening things that we can do even when people aren't having symptoms to kind of pick up, is something starting to develop. And then we have some imaging techniques that look at the heart. There's one called the Meghana scan. That's been done for many, many years, and that measures the ejection fraction. All those anthracycline studies that were done in the 50s and 60s and 70s, all of that was done with Meghana scans. We don't do them as much anymore because you do have to get some radiation to get that Meghana scan, and it's a bit limited because really all it gives you is the ejection fraction. We're now doing a lot more of called echocardiography. You've heard this a couple of times tonight. There's no radiation exposure. It's very easy to do. It takes about 15 to 20 minutes. They put a little jelly on your chest. It's ultrasound. What else is useful about that? Well, we can also pick up valvular disease. We can pick up fluid around the heart. That's called a pericardial effusion. We can look at the ejection fraction, which tells us how well the heart's working. I mentioned this other technique called strain to try to pick up if the twisting is having a problem early. So these are the kinds of things we do. And then we even have something called a cardiac MRI, which is really kind of the gold standard for looking at heart function. We do use MRIs. Sometimes it's difficult to get good pictures with echocardiography, and in particular breast cancer patients. Someone's had a breast implant, or someone's had, it can be very difficult. You can get very difficult to get images, and MRI can, not get you over that hump. So these are the kinds of things that we do pretty regularly to try to follow and figure out how patients are doing. So this is just a scheme, kind of pulling it all together. Oncology, hematology patient, which we've just given you 2 examples of. So we'll start off. There's 3 different components to cardio-oncology. There's before treatment. So this is the patient who presents to Dr. Raghavendra. She's assessing what's going on, figuring out what chemotherapy regimen, but she's saying, hey, does this patient have cardiovascular risk before whatever therapy we're going to give this patient? Do they have heart failure history? Do they have coronary artery disease? Do they have high blood pressure? Do they have any of these other sorts of things that I mentioned? Women, younger or older? And if you have some of those things and you're thinking about, hey, this chemotherapy I'm going to give could be potentially toxic, there it is, cardio-oncology consultation before you even start therapy. Okay, so that's one component. The second component, which is really the vast majority of what we do in cardio-oncology, is during treatment. So like the patient, the scenarios we had, the patients were started on chemotherapy, things were going along, and then they started getting short of breath. Fluid started building up in the legs. They went into congestive heart failure. And so these are those cardiovascular complications, a decline or reduction in their ejection fraction. Is there fluid around the heart? Are those biomarkers, those troponins and those BNPs starting to go up? Are they developing any arrhythmias, uncontrolled high blood pressure? Those things happen. And if any of those things happen during treatment, cardio-oncology consultation. This is where we have those open lines of communication. And then finally, another piece that we really have to start thinking about is after treatment. Okay, so early on I told you about the survivor, the breast cancer survivors are, their outcomes are so much better. They're not dying from their cancer. The majority are dying from cardiovascular disease. And so afterwards, you know, we have to think about, and the reason is because they've been exposed. A lot of those folks with left-sided breast cancer have received radiation to the left side. The heart sits right under the left breast. A lot of them have received that anthracycline. And so there's a lot of risk there. And so in those folks, we really want to have them, you know, see us after their treatment is done to help set up the survivorship program. Do we need to get them into, and this is a really new exciting area of cardio-oncology, there's new evidence to suggest that exercise can impact not only cancer outcomes, but heart outcomes. We know about heart outcomes, but it can actually improve cancer outcomes. And so there's our rehabilitation programs. There's something called CORE, which is Cardio-Oncology Rehabilitation. And we're one of the first sites really trying to put this together. We had a terrific exercise physiologist from Memorial Sloan Kettering named Jessica Scott. She had worked with NASA on why astronauts come back after just 6 months in space and they're completely deconditioned when they come back down to Earth. Like they've aged 25 years in 6 months. It's really pretty amazing. And so she helped develop a lot of the technology. Like they have these treadmills that are on the wall in the space station, all without gravity, right? So if you don't have gravity, your physiology, your body starts to really tank. So you have to constantly do exercise while you're up there. And she did a lot of that pioneering work, and what she is finding now is that cancer survivors look, when she looks physiologically, a lot like the astronaut who comes back down to Earth. There's just this inability, exercise capacity is reduced. Even though they feel fine, the cancer's gone, but they just aren't able to exercise as much. They get short of breath easier. Their heart rates just don't get up the way they should. And so she is doing some pioneering work, and we're going to be collaborating with her on putting together a program after chemotherapy is done, after you're in remission, the patient is in remission, to try to improve exercise capacity, improve quality of life, all of these things. And so that is a whole new area that's really untapped, but we're actually several in the back here are helping us with this program. So those are the kinds of things. So before treatment, during treatment, and then in the survivorship period. You can see the 3 different phases, and this is where we try to link and network with our oncologists. We try to be as accessible as we can. We all call each other quite frequently, and we're here to help. And I think that's the key takeaway, is that the cardiologist is not here. This is a big message. We are not here to stop chemotherapy. That is the last thing we want to do. We want patients to continue chemotherapy, but do it safely. Right? We want them to get through it without any kind of complications, and that's the goal of cardio-oncology. So what do we do at Franciscan Health? This is just a quick diagram that lets you know who we have. That we have 10 oncologists. That number is always changing, so this may not be up to date, but 10 oncologists as of when I made this slide. We have 4 cardiologists, including myself. We have 2 nurse navigators. We have Holly Page in the back here, and we have Carrie Skirka. I call them our cardio-oncology angels, because they literally are behind the scenes looking out for all of our cancer patients. They just do an amazing job, and we really couldn't do this clinic without them. They live in the oncology arena, so they work with Dr. Raghavendra and all the other oncologists, and they have cardiovascular background, which is really amazing. They, really liaise with the patients and with the docs, and a really terrific thing. We have a medical assistant that's dedicated. We actually have a half-day clinic dedicated to nothing but cardio-oncology, a half day every 2 weeks. And we'll see patients, new consultations, we'll see folks who are in their therapy, we'll see patients in the survivorship period. So that's 3 different components. And again, we do a lot of things in terms of prevention and screening. We're doing a lot of education. So that's one of my big emphasis now, is a global perspective, trying to educate. There's cardio-oncology programs that are developing all over the world now, Australia, South Africa, Japan, and we're trying to really communicate this in a way that people around the globe can get this information easily. And we're even within the state of Indiana, we're trying to do a telemedicine initiative so that patients who can't come to us, we can actually use technology and be able to do a lot of this, consultation just over the internet. And then lastly, research. Research is so important. It's a new field. This field's probably been around about 7-8 years. It certainly goes back to the old anthracycline days, but things are moving at light speed, okay? There are so many new therapies coming out every month. And it's extremely exciting because there's so many new great therapies for patients with cancer. But again, part of what we are doing is we're sitting here on the back going, this is great, but let's observe, let's record what's happening, let's make sure there aren't any heart toxicities due to some of these drugs, and prevent them. So with that, I will finish our talk, and we'll open it up. Dr. Raghavendra, if you want to come back up, and we'll be happy to answer any questions you guys have about cardio-oncology or anything specific that has anything to do with cancer or movies or anything else, or I'll just defer to Dr. Raghavendra. Thank you very much. Thank you for all your time.
I have HER2 positive with my second breast cancer, and I noticed the drugs that you had in the cocktail. I went through everything. I have heart problems that came out when I got the chemotherapy. And they Dr. Vivo, they got me down to where I'm healthy at the moment. But I noticed the drugs that you had up there, and 2 of them I took, and then when it was time for me, the one with the T, I got afterwards, but the one with the P, my insurance wouldn't pay for. And I heard Dr. Badia say 5 years to somebody, and she shook her head and said yes. So I'm thinking, I've got 3 more years to wait, and I'm going to have some problems come up. What's happening with the insurance industry?
Well, that's the question of the hour, the second every day, isn't it? But I think for patients who have early breast cancer, so where our goal is to say, let's do surgery, let's do radiation, but if you have the high risk features, then depending on the stage of cancer, the treatment's a little different. For patients who have a smaller tumor that has not necessarily gone to the lymph node yet.
Oh, mine did.
Yeah, but typically for those tumors, we only tend to use trastuzumab, or just Herceptin. But if it is a larger tumor that has involved the lymph node and is HER2 positive, then the current FDA approval is for combination treatment. Okay, I cannot answer specifically as to why your insurance might have denied it, but if it is a lymph node positive cancer, if it typically is a tumor that's larger than an inch in size, we would use combination treatment.
I got them all
You
at
did.
one time,
You
and
did,
then
yes.
when they did the after
Correct.
treatment, I
Yes.
just got Herceptin.
And that's
And
appropriate.
They wouldn't pay for the other drug that
Yes.
they wanted to give me.
Correct, so that is appropriate, because there is a trial, I think what they're alluding to is there is a trial which looked at whether continuing double therapy, both the Herceptin and pertuzumab, after somebody had surgery, if they had high-risk disease, there was one trial that showed a marginal benefit, and that is a very personal decision between the oncologist and the patient, particularly in someone who has heart disease. We try to avoid adding more and more heart toxic medicine
Thank you.
to it, so maybe that might have been a reasoning as to why, but I will tell you, I don't think that's either a right or a wrong thing to do. It's truly very, very specific to each patient and each pathology. Any other questions?
I do have a question about the first case study, when you replaced I can't remember which one it was, the dox, what was it?
Doxorubicin?
Yeah, doxorubicin with the other one, why wouldn't you, I mean, I guess it maybe goes into a lot of like the pharmacology of the medicine, like why wouldn't you just start with that one to
Start with
begin
that.
with?
So we will, because the R-CHOP is slightly superior to the RCDOP
Okay,
regimen. So it's still it's a good option, but it's still a second best option.
yeah, so you're looking at the effectiveness, and
Correct.
like balancing the effectiveness with the risk.
With the
so,
side effects.
okay.
And I'll tell you that, I think if I have a patient, and we have patients where we have patients who have established significant congestive heart failure,
Yeah.
who will walk in with, who have lymphoma, and we have to choose a treatment, and in those patients, we will typically just still start out with our CDOP.
Yeah.
So knowing that the more aggressive treatment regimen might not sustain their heart function.
Right.
And that's a compromise we make, but if we can, we always want to choose the best treatment option available, but then if not, then we will accept.
Second one, yeah, sure.
When you start looking at the cardio challenges, have you noticed there's a time frame from like when treatment ended? Within 10 years you're seeing more, or 15, 20, or is it the whole lifetime, or, you know, when is it being a little bit more pronounced that you've noticed?
That's a great question.
Yeah.
You know, I think before cardio-oncology really got established, just in my own practice, I would see folks 10, 15, 20 years from their therapy. And a lot of that were children who received high-dose anthracyclines, you know, Hodgkin's, non-Hodgkin's lymphoma. They would get radiation, they would get chemotherapy, and they were fine. And then I would see them at about 40. So typically 20, you know, early. So you wouldn't normally see cardiovascular disease in somebody until usually the 60s and 70s, typically. But we would see some of those folks in my clinic who would come in with heart attacks in their 40s, or they would have, you know, it's one of those things that, the way I always looked at it from a biologic perspective, it was kind of like this, what's called a two-hit hypothesis. The heart, they could be doing perfectly fine, but that one exposure, and again, remember, those high-dose exposure, which we don't see as much anymore, but those folks are just kind of doing okay until something happens. Either they go into an irregular rhythm, or they have a mild heart attack, or something, and then instead of it just being a mild thing, it becomes a much bigger thing. So the sort of protective pathways are not there. And so that is kind of what I saw. And it typically, I mean, in that situation, it was 20, 30 years post. We haven't been doing it long enough now to really know the long-term sort of things. But, you know, and it really depends on the type of chemotherapy you get. The anthracycline piece it's kind of like a fixed thing. Whatever happens, happens. The Herceptin piece, which we just talked about, is reversible. Like we said, Dr. Raghavendra said, we'll hold it for a month, we'll get them on heart protective therapies, and a vast majority of people will be able to get back on Herceptin and finish their therapies. And we do want to keep an eye on them longer term, to your point, and that's kind of the survivorship piece. But every kind of chemo is a little bit different. The anthracycline piece, we tend to think longer term. The Herceptin thing tends to be more short term and reversible, and likely doesn't have long-term effects. So, but again, a lot of this is work in progress. Where many of these new therapies, we just, you know, we're just learning about the toxicities and when do they occur.
Thank you.
That's a great question. Don.
Are you prescribing exercise during treatment or after treatment, or how are you working exercise into your care?
That's a great question. So that's part of the whole concept behind cardio-oncology rehab core. We are, you know, this is all in its infant stages. We are really at this point focusing on the survivorship period. There is accumulating evidence, as Jessica Scott presented to us, that even exercise during chemotherapy actually it's a little complicated because it has to do with the type of tumor and the type of exercise you get. But there are studies now showing benefit, not only to quality of life, but actually improved cancer outcomes by exercising. So the specific prescription is where we're kind of getting caught up at this point, because you have to, from what my take is on the literature, it really depends on the type of tumor. For example, the hormone positivity versus negativity has an impact on the specific type of exercise. It's very complicated. I think certainly it's reasonable to say, walk, get your steps in. You know, sitting is bad, no matter what you think about it. You know, it's hard because, you know, folks are really not feeling good. They're tired, they're exhausted, they don't want to do a whole lot because they're in the midst of getting chemotherapy, right? I get it. Diarrhea, nausea, lack of appetite, there's a lot of those issues, and depression, which can be a big part of this. And, you know, exercise we know can improve depression. It can help with fatigue. So, you know, to whatever extent that somebody can do it, as far as, you know, we are not currently prescribing exercise regimens, but maybe you can comment from the oncology perspective. But
I think Dr. Rao is exactly right. I think there's more and more research interest, more and more data that is coming through saying exercise is going to be a definite positive influencer in how patients do with cancer. I think what we realize is, you know, when we start disease, and then we say, what are the risk factors for cancer? There's a significant overlap, right? I mean, age, the patients, as we start getting older, you start noticing that their risk of heart disease is getting higher, well, their risk of cancer is getting higher too. Smoking influences both, right? So as we are gaining weight, there's increased risk of cancer as well as increased risk of heart disease, cholesterol issues, diabetes. So all of those which contribute to heart disease are also risk factors for cancer. So there's a lot of overlap. And we know from heart disease data that the more you exercise, the more active you are, the better you do from your heart perspective. Well, then it should translate to cancer as well. So this is not surprising, but it's a long time coming, and we're all very excited to say, hey, let's get on with it. Let's make sure that we keep our patients active. And we are telling our patients, I'll tell them every day. Every day I see them 30 minutes, 3 times a week at least of active exercise program, not just taking a walk around the neighborhood, but make it count. So 30 minutes, 3 times a week is where we are right now. If we can do more than that. Patients who are marathon runners before their cancer treatment, do not stop running while you're doing your cancer treatment. So it might be a more, lesser duration, but keep up with it. So keeping up with activity is very, very important. Yeah, definitely makes a difference.
So you think dancing is a good idea?
Absolutely. Where are you going? Before or after drinks?
I don't drink, but I go dancing all the time.
Dancing is
I went
great.
ballroom dancing today.
Did you? That's fantastic.
Fabulous
That's
exercise.
fantastic.
And I'm trying to get square dancing started.
Wow, that's awesome. No, it is really good. I think dancing, it just is good from an endorphin standpoint. It helps you feel great, feel better. It's definitely exercise. Yeah. Any other questions?
And the other piece is, I think this is a support network as well, is to think about exercise as groups of people, both in terms of survivorship is really important, to share experiences with other people, to not feel closed off, to be able to help others who are going through this journey and this path. And I think exercise is another way that if you can get an exercise group together, that's another fabulous way to do that. And cancer survivors can get together and do exercise programs together. And I think there's so much benefit to being in groups, to giving your experience and to hearing others and realizing you're not the only one going through something that's really difficult. So I would encourage everybody, and you all know that as you're part of this organization, but from the exercise perspective too, just it's super important.
Yeah, and I know Cancer Support Community has yoga classes and we have other things, so that's awesome. I think from our standpoint, the take-home point is that it's important for you to understand that we are looking at you as a person. We're looking at you not just as a disease and a treatment, but as a whole person, and we work together to make sure that we take care of you as well. So there's a lot behind the scenes that coordinating that happens, and we have, like I said, a wonderful team that works with us to make that happen too. So as we go forward, more and more treatments which are exciting, not chemotherapy, but good treatments for cancer is coming along, we know there are other consequences, particularly heart related, but we work together to make sure that we deliver the best care possible for you guys. All right.
I have a hard time when I'm hungry. Now, I pick up protein bars. That gives me the energy to go ahead and do something. What would you suggest instead of picking up a good tasting protein bar?
Protein bars are great. I think as long as we see a good balanced protein bar, that's, as opposed to a bag of chips, protein bars are awesome. That's what I go to.
Yeah, well-balanced meal. Lots of fruits and vegetables, really, really important. Of course, from the heart side of it, try to cut down on the red meat. Really try to do some of the, chicken and fish, and just stay away. I'm as guilty as anybody for the fried stuff, but stay away from it. It's really, really bad. Bake and grill things. Just a really nice, balanced, healthy diet is the way to go. And snack-wise, protein bars definitely are reasonable to do. And Sure is another. Those kind of boost. Those have a lot of nutrients and a lot of protein. Those can also be very helpful, particularly when you're fatigued.
Well, thank you very much. Thank you all for coming tonight, and thank you, Dr. Rao and Dr. Raghavendra. If there was a question that you didn't want to ask in front of the group, they'll hang around for just a little bit and maybe answer that. But we appreciate the Cancer Support Community allowing us to come here and provide the education, and give your feedback to them on any other topics that you would like to see covered, and I'm sure that they would accommodate. So thanks again for coming tonight.